Good morning. My name is Saran Ephraim, and I am a member of the Georgia HPV Work Group, which is a subgroup of the Georgia Cancer Control Consortium. The HPV Work Group is comprised of members representing universities, medical health systems, including hospitals, community cancer coalitions, the American Cancer Society, Georgia Department of Public Health, and pharmaceutical partners. Today's offering is the first in a three-part series, HPV Vaccinations, Getting Back on Track. I am a co-lead of the Health Systems and Social Engagement Subcommittee within the HPV Work Group, along with my co-lead, Tanya Phillips, who is here with us today. We're going to take a few minutes and watch this brief video.
The Republican legislation, which addresses many of the issues.
To obtain CE credits for today, you must be in attendance for the full duration of today's activity. And then you must also complete and submit your evaluations by October 14th of this year. And you will receive a direct link to that evaluation after the completion of today's webinar, along with it coming in an email the day after today's webinar. And once you've completed your evaluations, a certificate of attendance will be sent to you by email on October 15th after you complete the evaluations. There are no conflict of interest that exists for any individuals in the position to control the content of today's webinar. Just a few housekeeping matters. Your video and audio has been disabled. So if you have a question, please utilize the chat box to pose questions and let us know if your question is for the first presenter or the second presenter. And just a friendly reminder, if you're seeking continued education credits for today's presentation, you must be in attendance for the full duration of the presentation and submit your evaluations. Today's first presenter is Barbara Coleman of Cobb Pediatric Associates. Barbara has over 30 years of business experience across multiple industries, specializing in account management, project management, and software development. Barbara holds a BS in computer science. She joined Cobb Pediatric Associates in 2018 as practice administrator when Maggie Peters retired after nearly 30 years. She works closely with Dr. Denise Nakos, the practice's quality champion. Barbara is not only practice administrator there, but her two children, now at Georgia Tech, were both patients of the practice since birth, giving her a good parent's perspective of the pediatric world. Thank you for joining us, Barbara. I'm going to turn it over to you.
Thank you very much, Saran, and I appreciate everyone joining in to hear what our results of our Georgia AAP adolescent vaccine campaign was. This was done in 2019. We learned a whole lot of things, and we're continuing to implement the lessons learned today. We had a great team. That was one of the keys to our success. Dr. Denise Nakos, our quality champion for the practice, was our lead, along with Dr. Beatrice Wilder. Vola Estes, a clinical supervisor who just celebrated her 35th anniversary with the practice. Vonda Molden, a senior MA who has been with the practice over 20 years, and myself was the team. And our objective was simple: increase our adolescent immunization rates. We worked closely with Noreen DeHill and Shanrita McLean and all of the people at the Georgia AAP, trying to bring our GRITS numbers in line. They provided us monthly reports that showed very valuable information. One of the biggest things that we saw was in GRITS, we would have the same patient listed several times. They were either duplicate entries or they were inactive. Most of our duplicates resulted from misspellings in the name, or cases where they'd gone to a different, like an urgent care or something. There was a new name that was entered, last name, multiple last names, just errors, and they carried forward to GRITS. So we might have, you know, up to 5 or 10 entries for the same single patient. So those reports were very valuable in helping us clear out duplications, and of course inactive patients that had aged out of our practice, moved to another state, anything like that. It was great value. We used those reports and targeted, once we had cleaned them up, to provide just our active patients. Then we used those reports to target our patients in need. And we presented monthly call lists to Vonda, our experienced MA, and she reached out personally to each and every family. And she consistently scheduled 56 to 58% of our patients for office visits. Once we got them in the office, we did, of course, quick check with GRITS, completed all of their immunizations, gave them their checkups, and really tightened up the practices we had for making sure that our patients, especially our adolescents, were properly vaccinated. That's a hard age range to make sure we capture all of the vaccines and get them in the office, because they're so busy and so independent at that time. So we've incorporated Vonda's permanent position as our liaison out to our patients to make sure that we bring all of our checkups in and keep our numbers way up there. So as a permanent part of our practices, that's what we're doing. This was our HPV slide, where you can see we were in the 40s the first month when we started, and as soon as we cleaned up the GRITS and we got our MA on the phone reaching out to our patients, we already jumped to mid-70s. So it was a big increase, and we consistently kept it up there, and then the numbers even grow further by the time the survey has finished, the initiative finished, and we continued. The next slide shows the MCV4, which was also a number that grew by at least 25%. And again, we've maintained those numbers and exceeded this particular slide currently. We're even beyond that. So that was pretty much that. And then the Tdap one, of course, is another one. So all of those adolescent vaccines, we saw an improvement just by reaching out to our patients on the telephone of about 20 to 25%. People think nowadays, oh, no one has time for telephone calls, but they really do. And when your pediatrician calls you and they know that an MA on the other end knows your family, has personal details, and remembers stories when this child was born, and now they're a teenager, and now they're 15, now they're thinking of going to college. That sort of personal touch reaches parents really closely, and they know that their doctors are behind them calling as well. So this initiative really brought back around. A lot of times people think pediatricians are just for the babies, and once they're adolescents and they're teenagers, it becomes less of a priority in their life. We want them to know we're there until they age out of the practice and even beyond. If they need to come back and have advice, they need to talk to us about, something they want to do in their career or mentor. Many of our doctors mentor kids in college now that are looking to be pediatricians. We've had several patients come through here as prospective doctors. So they try to stay in the lives of our patients as a family, not just a number. This was the PDSA worksheet that the Georgia AAP provided to us for the initiative, and it was really valuable. The PDSA plan, do, study, and act. So we would meet each month with this particular worksheet and come up with new initiatives and updates to what we were doing. So for all the months that we completed, I think we had 6 or 7 of them throughout, we would first give an idea about what we were planning to do and how we were implementing the changes to to show those improvements or track what we were doing and assign responsibilities. When you have a form like this in a group meeting, it's much easier for people to raise their hand and take on the responsibility, or to explain what they were doing, what their success and failures were in those different environments. It's a good vehicle for running the meeting and actually tracking the progress. So this was a valuable piece. And then of course at the end, we decided to adopt pretty much everything that we discovered going out. In one particular piece of data on here, for 306 personal calls, 181 visits were scheduled. That's a fantastic number. So we really think that that personal touch was vital to us making such a big leap in our numbers. We also hosted the on-site EPIC training. I have to give a kudos to Barbara Turner, who did a fantastic job. We had 2 of the sessions, immunizing adolescents and improving HPV vaccination rates in your practice. She has lots of good tidbits and phrases to use when you're trying to reach your parents, who are usually the ones that are presenting the concern of having their child, their teenager, vaccinated with HPV. They're worried about promoting promiscuity and things like that, and they just don't want to have the idea of their teenagers having any relations. So we tried to use her good tips, and our doctors are very patient in speaking to the parents and fielding all the questions and concerns that they may have. We would have the monthly meetings. As I said previously, those internal meetings, we were very open to brainstorming ideas anybody came up with. We entertained as a possibility, and then the whole office knew that this had become a real focus of 2 of our lead and most senior doctors. So that added another layer of success. Gardasil also provided us great collateral and handouts, both in Spanish and English, to give to our parents to take home for discussion and talk points, so that we could get this out in the open and realize that this is a vaccination against cancer, regardless of boy, girl. This is a real thing that people need to use and really can make a change in their lives, not as children, but even as adults and on later in life. So our physicians were very, very liberal in handing out our Gardasil handouts. And lastly, we instituted these 6-month reminders in the patient portal, and figured out that a lot of our patients had not provided valid emails. So we would just, mail them a straight postcard, and it was very effective in getting people to come back for their 2nd and 3rd shot. So the reports from our EMR, we used those, and we saw that our volume for adolescent checkup was off the charts for last summer. We had more adolescents in the office last summer than in any previous year. And this practice has been in operation over 40 years. So this was really successful for us. And we've also seen a broadened awareness and acceptance of the HPV vaccine from our patients and our parents. And our parents talk to each other. And you have school systems, and when parents are doing it, it's almost a rolling positive. So they go forward and get other parents to do it. They talk about it, and we're also available to talk about it anytime. And at the end of it, we actually received the HPV Vaccine Champion Award for Georgia. We were very flattered and really excited about receiving this award. It was just almost a bonus at the end. We were so happy to see so many of our patients coming in and getting their adolescent shots and getting up to date and having those really hard conversations that needed to be started in their families. And lo and behold, we won the award as well. So it was really a double plus. It was very exciting. And today, we are continuing to maintain our great successful immunization rates. If you see we're well above any of the dots which show the Georgia averages. The HPV 3rd shot, we actually have eliminated almost the need for that, because we start at 11-year-old checkup. And that's a great success point for us. I know you can start even sooner, but the 11-year-old is a really good one that we found with our population. And we also encourage them, if you go in and start now, then you only have to get 2 vaccines instead of 3. It doesn't sound like that big of a deal, but it really is. You will be amazed at how many people will say, the patients will actually say, well, I'll go in and do that. And that provides the additional positive push that the parents need to go in and say, yes, we will do it. As I said, we generally don't need a 3rd dose unless they chose to decline or delay, or they've transferred out of the practice. So some of those numbers will still be in there, but that number is particularly low because of our early success. And you can see our numbers are still very high for our Tdap and the Menveo, and now the HPV is still high. The second dose is still well above average for the state, and we're really running well within the numbers. And we feel like even with COVID going on in the last 6 months, we've been able to maintain our adolescent acceptance rate for the vaccine. So COVID specific problems, we lost about 50% of our volume during the worst point of COVID. I know a lot of practices chose to close, but our doctors did not want to. They wanted to remain open and available for our patient population. We instituted a lot of telehealth during that time. We found that our patients were willing to come in anyway. They wanted to see their doctor and maintain that personal relationship. We didn't have a lot of people even accept the telehealth, which was very surprising. So I think that they do believe the doctors are behind them, the practice is behind them, and they want us to be successful in taking care of their children and providing the best care that we possibly can. We have now rebounded to about 70% of our normal volume, and we anticipate that to continue growing as our students go back to face-to-face operations. And one of our big factors for getting the patients into the practice was our focus on personal reassurance of safety. We did that again with Vonda, our senior MA, when she's calling the patients to bring them in for checkups. She also was making calls for near checkup time patients to let them know that they're safe to come in the practice. It's clear, it's clean, we're doing extraordinary measures to keep it safe for the families, for the parents, for the staff, everybody. So we have MDs available as well. Our entire practice is all MD, and they're available at any time to discuss parent concerns over safety, over HPV, over anything that their parents want to speak about. Our MAs will usually take a message and the doctors will get back to them. So it's a very hands-on practice. We also use regular social media posts constantly. We would talk about our updates in the office in Spanish and English on our website, on the Facebook, on the patient portal. We did a lot of bulletin board notifications and texts and emails, and just continued to remind them of the importance of maintaining their vaccination schedules. And we continue with our 6-month reminders, email and postcards.
Thank you so very much, Barbara. This is wonderful information, and congratulations again for receiving the HPV Champion Award.
Thank
That's
you.
a great accomplishment. We're going to go ahead and ask a poll question at the moment. Right. So the question is asking you to select the methods the Cobb Pediatric Associates implemented to improve their HPV immunization rates. So I'm going to go ahead and give you a few seconds to go ahead and complete that poll. Thank you so much for completing this poll. I'm going to go ahead and end the poll and share the responses. So we asked what methods the Cobb Pediatric Associates implemented to improve their HPV immunization rates. The options were A, Cobb Pediatric Associates hosted on-site EPIC trainings. B, monthly meetings helped to promote collaboration and brainstorm in addition to keeping staff focused. C, patients were sent postcard reminders if they didn't have an email address on file. D, patients were only reminded of their next shot upon revisiting clinic for well or sick office visits. And the correct answer is actually E. Responses A, B, and C were utilized to increase their HPV immunization rates. Thank you again for completing that poll. At this time, we ask if there are any questions that have been posed for Barbara. At this time, we'll go ahead and answer a few of them. And if we do not have any questions, we will go ahead and move on to our next presenter.
Thank you, Saran. My name is Tanya Phillips, and I serve as the Senior Manager for the American Cancer Society's Cancer Control State Partnerships. I am pleased to introduce one of my colleagues, Anna Hassan. Anna is the Senior Intervention Manager of HPV vaccination here at the Society. She has a Master's of Public Health in Epidemiology, and she has managed projects in diabetes, reproductive health, health education, and cancer prevention. She's passionate about engaging health systems in the fight against HPV cancers through quality improvement efforts. Good morning, Anna, and welcome to the call.
Hi, Tanya. Thank you. And thanks, Barbara, for your presentation. And thank all of you for joining us for this hour of HPV vaccination fun and getting back on track. So my presentation follows guideline updates and impact of COVID-19. On the next slide, you'll see I have no financial conflict of interest. And then on the next slide, you'll see my objectives. So I really have these two major buckets I want to cover with you in the next 10 to 12, 15-ish minutes. So the first one is just making sure I'm zooming out a little bit from Barbara's awesome on-the-ground story. I am from American Cancer Society, as Tanya said, her colleague. My main focus is on the national team and quality improvement in our interventions. But we also have our guidelines that have been updated recently. So I just wanted to make sure y'all had that information. And then the second component, second bucket I want to cover is some what we've heard nationally from the field on some tips around getting back on track, although it's a continuous learning curve. Next slide. So first and foremost, recommendations. So of course, we're the American Cancer Society. Barbara said it beautifully. HPV vaccination is cancer prevention. So the guidelines here are still with that being our core. And the three elements I want to talk about today, I'll start with number one, of course, is that our main focus for girls and boys should get 2 doses of the HPV vaccine at ages 9 to 12 years old, with the ultimate aim of having series completion by 13. Number 2, children and young adults up to age 26. So before there was some differentiation between male and female. There was you don't need to go back not to confuse you, but now male, female up to 26, the American Cancer Society has in their recommendations who have not received the HPV vaccine should get vaccinated. Vaccination of these young adults, we know, is not as effective as those at younger ages. And really quick, if we can go back to the previous slide, I just want to cover that third element. So the young adults, we know, these groups above 13 will not see as much coverage and protection as those at younger ages. And there's a bunch of different elements due to exposure, as well as other elements. And lastly, ACS does not recommend HPV vaccinations for persons above 26, so that 27 to 45 age group, predominantly because it doesn't show as much effectiveness considering resources that are available. Next slide. Thank you. So really, essentially, our recommendation, the HPV vaccination can prevent 6 types of cancers. We encourage healthcare providers to start offering the HPV vaccine at 9 and 10 to achieve higher on-time vaccination rates, which will ultimately lead to increased numbers of cancers prevented. And I want to make a caveat here. The next slide, which we can go to, just tells you why it's the benefits of 9 and 10 and why ACS decided to kind of focus in on this 9 to 12, where previously we were focusing mostly on 11 to 12. I want to say blanketed that both are awesome. We just know that there are some advantages to starting at 9. So if you're doing the bundled approach at 11 and 12, beautiful. If you want to go down to 9 and 10, we know it's been advantageous for a lot of our partners and parents. Here's a kind of, not exhaustive list, but a few elements that we've heard from both literature and anecdotally of benefits. So earlier initiation gives you more time to finish it. There's a less likelihood of exposure before you're vaccinated, if you're vaccinated at that younger age. Ultimately, it can increase vaccination rates. It decreases the discussion around sexual activity. It can decrease the requirement, the discussions around required when you bundle it with meningococcal and Tdap, which are nationally more likely to be school mandated. And of course, less visits, less shots, which Barbara mentioned. And in the literature, it's been shown to be acceptable to parents. They haven't had as much pushback as maybe we would have assumed or maybe thought. Next slide. So now I'm going to shift gears. So I wanted to make sure you feel comfortable with the guideline updates. Those are all on cancer.org/HPV. Now I'm going to focus in on what you came here to learn. So getting adolescent vaccinations back on track. So we want to focus on the impact of COVID-19 on adolescent immunizations. Next slide. So let's take a step back. So this is pre-pandemic, which is a crazy thing to think about. But if we go back there, we know that already HPV vaccination lagged behind other vaccines. So what are you looking at here? So on the right, you'll see, so the data I'm going to show you on this slide and the next one are from NIST, the CDC, focuses on that 13 to 17-year-olds age group. This is the data we get annually in about August. So this is from 2019. So we know that we were failing to protect our children from future HPV cancers and pre-cancers before the pandemic because of how we were vaccinating for HPV versus how we were vaccinating for Tdap and meningococcal. So the graph you see here, just to orient you, are each bar, different colors are labeled below. So Tdap, meningococcus, meningitis, and HPV. And along the left side is the vaccination rate. Here we're looking at completion of HPV. So we know that initiation is around 70%, which is great, but completion is what's denoted here. And we know that we're really vaccinating much less than Tdap and meningitis nationally. Next slide. So we're already starting kind of far behind. This slide is looking at a different perspective. So this is looking at, this is data from the CDC as well, and this is around VFC, so the Vaccine for Children program, and how much ordering data they have. So ordering the HPV vaccine. So if we go from left to right, it's time. And what you'll see is different color bars. You'll see a gray bar and a green bar. So the gray bar is over time, how much HPV vaccination was being, how many doses were being ordered. And so you'll see there's a differentiation between gray and green. The 1 and 2 that you see there, those vertical lines, the 1 is the first case of COVID-19. And the 2 is when there was a US national emergency declared. So you see really after that emergency was declared, you'll see a larger differentiation in what was ordered in 2019 versus 2020. Please note this data goes up through July, and we do see some promising results, both anecdotally from Barbara's practice, but also here that there has been an increase in doses of HPV being ordered that look a bit more like 2019. So it's definitely a story that is affecting many, but there's some optimism there that we may be able to swing back and maintain our visits and doses of HPV. Next slide. So that's to say, there's a compelling quote here that resonated with my team and I wanted to share with you. This is a quote from a Miami Herald article, Dr. Christina Johns at PM Pediatrics. If we are not smart now about making sure that kids stay on schedule in terms of getting their immunizations, we may be inadvertently creating another public health problem, just as we're trying to manage this one. And so I know I'm preaching to the choir. You wouldn't be here if you didn't value this, but it's just something that resonated with our team and I wanted to share with you. So let's get down to the good stuff. Next slide. So I'm going to talk you through, there's 3 different slides that kind of look like this, different immunization strategies that we've heard nationally have been used and have been effective. So let's start with parent-focused ones. Initiating reminder and recalls. We heard that in live time in the last presentation. This initiating reminders and recalls has been an effective way to engage parents. Secondly, proactively communicating about safety protocols. We know this is one of the barriers that's being reported as to why parents may not be coming in. And so ensuring that you're both calling them to bring them in and also reassuring them of your safety protocols. Next slide. So the other aspect of immunization strategies we can look at, we just look at parent-focused ones. Here's the structural barriers. I'm going to read you through this list, the little icons, give you a spoiler of what they are, but expanded clinic hours, vaccine-only clinics, mobile immunization units, drive-up or drive-through immunization, off-site immunizations, for example, pharmacies or schools, and expanding staff who recommend the vaccine. So something like standing orders. Many systems already have standing orders in place. So some systems have decided to expand or create standing orders in this time to get their immunizations back up. And then I'll go to a third element here. So another kind of way to address it. So we've addressed some of the parents. These are not exhaustive, of course. These are just things we've heard. We've addressed the parents. Here's the structural barriers. On the next slide, we're going to look at a kind of our third aspect of strategies that we've heard from the field. So prioritization. So reducing missed opportunities, vaccinating at sick visits, and a focus on reminder recalls on overdue patients. So we know from just the national data that there were less doses being ordered. So we could extrapolate that there were less doses being given at that time. And so every month people become due, right? And so some practices have decided to focus on those who are the most overdue first and work their way back. Knowing that takes resources and time, which are sometimes a luxury, but that has been an approach that's been shared with us that was effective. Next slide. So those are kind of tangible things that we've heard. Now I'm going to walk you through a bunch of different resources. So you don't have to memorize these. You'll have the links to these after. And this is a website that's being continuously updated. So as I said, I'm an American Cancer Society staff. My focus is really internal to ACS and our health partners. These slides are from the HPV Vaccination Roundtable, which is our partner who focuses mostly on external other organizations. And so we're all connected, but this specific website is a compilation of hundreds of other organizations. So it's representative of more than just ACS or CDC. So there's a ton of good stuff there, probably from your own organizations who've joined us today. So let's get into it. What are some back on track resources? This is my last segment for today. So I'm going to just go through a couple of them. So on the next slide, you'll see kind of a summary of goodies that are there. Some subsequent slides, I focus in on a few, but just to give you a layout of the land, the Getting Adolescent Vaccinations Back on Track webpage has a few different things. So much like our immunization strategies that we just covered, focused on providers, focused on parents, these tools do the same. So you'll find there's some video content. So there are videos, one of which we saw before we started the presentation that Saran shared. There's videos that focus on health systems. There's videos that are focused on parents, and they're short and can be shared. There are infographics that really represent the content from the videos, but in a paper form. And then there's a list of various resources from all different organizations on tips and tricks, stencils, examples, etc. So on the next slide, let me just show you what they look like. So here are some of the videos for health systems. You'll see this is a playlist. So once you click the link, I'm sorry for whoever's having to share all these links, but so this is a playlist for specifically the audience is actions that health systems can take. Next slide. These are for parents. So looks similar when you go into the link. It's a playlist. Some providers or some health systems have added these to their social media, their waiting room, who one person at a time can see it. There's a bunch of different ways to share this content. Whatever is good for you, it's there and available for you. Next slide. And then these interactive infographics, right? So I showed you a really small picture of them on the first slide, but I wanted to just zoom out here and show you that on the left side, again, it's for health systems, and on the right side, messages for parents. So messages around making them feel more comfortable, messages telling them that we could, it's imperative that we don't delay vaccination, etc. Next slide. So this is a fun one. So in July, we had a webinar. ACS partnered with HPV Vaccination Roundtable. We invited all of our partners that were working on clinical interventions around HPV vaccination. And it was a discussion-based webinar, and all of that, the kind of best practices and nuggets of wisdom and case studies were collapsed into this, on the right side, on the left side, you see it here. It's a summary document, which you can access the resource on the HPV Vaccination Roundtable, that same main link. And it's a couple pages long, breaks it down by topic area, and then highlights a few different states that shared their best practices around that. So that'll be shared with you at the end as well. And it really mirrors a lot of the information I've already covered. And what else is on there? I hope I'm not showing too much, but this is the last resource I'm showing you that's also on the webpage, is social media messages. So like we said, you could share any of those videos on social media. I know that's been an important way to get to your patients, but there's also social media messages that are stagnant. So little video clips and also just pictures that you could put on any social media platform. And those are all available on the HPV Vaccination website as well. Next slide. So my call to action for you, the journey that we just took in a short amount of time is I just highlighted the American Cancer Society HPV vaccination guidelines. That our hope is we can focus on 9 to 12 to get kids vaccinated early and protect them from cancer. And we really moved into getting back on track. We know this has affected us. It's inevitable. We have heard some great best practices from the nation, and we'll continue to collect that and populate that on the presentation. And I know that you have access in this 3-part series to continue learning with us as we learn more over the next 3 months. So my call to action to you is, how can your organization amplify these messages? And how can you add to the science too, so that we can continuously learn from you as well? That's all I wanted to leave you with. I will defer back to the organizers and happy to answer any questions that you may have.
Thank you so much, Anna. We appreciate you sharing such wonderful information with us today. It is time for our next poll question. All right. Please take a few seconds to answer the question in front of you about HPV vaccination recommendations. And if you do have questions, please go ahead and type them into the chat box, and we'll be more than happy to answer your questions. Okay, thank you so much for your responses. I'm going to go ahead and end the poll and go ahead and share the results. So the correct response was that the ACS recommends HPV vaccinations for girls and boys to receive 2 doses of HPV vaccine between the ages of 9 to 12. That is correct. We can go on to our next poll question, which is all right. This is our last poll question for today. Which is not a recommendation to address structural barriers to immunizations? I'm going to give you a few more seconds. Okay, all right, let me end the poll. And here are the results. And this was sort of a trick question because there were 2 correct answers in the list. So answers A and D were not the correct in this list. Sorry, that was a trick question that we kind of messed with you. But thank you so much for participating. There is a question that came up, and we'd like to ask our panelists. There is fear of COVID-19 phase 2 surge. What impact do you all feel this will have on vaccinations? Anna or Barbara, feel free to chime in.
Hi, yes, we've already started worrying about that ourselves. We know that, especially with Cobb County starting next week with the in-person, face-to-face, that's one of our major counties that feeds the practice that we take care of. So we are worrying about that, and we are making every effort to speak with our families proactively, reaching out to them, social media and telephone again, to let them know that we're preparing for anything in that nature. We're doing even more cleaning and sanitizing of our rooms, our waiting rooms. We offer also people that want to check in via car, so they let us know they're there, and they only come through when they're ready to go straight to a room. We've eliminated our waiting room. We have people that go straight. You literally are taken the minute you hit the front door straight to an exam room, which has been thoroughly sanitized. We make sure that our patients and parents see our staff fully masked 100% of the time, and if they're handling patients directly with goggles, using hand sanitizing and washing in front of the parents so that they see that when their child is going to be touched or handled, anyone handling them has washed in front of the parent. That actually makes a big difference to them so that they see that it happened. We provide additional wipe downs and paper if the parent wants to see the process in front of you, in front of them. We say, okay, and we clean the room again for them. So we're trying to really respond to the parents so they understand that we're doing everything we can to protect them. We're talking to the air conditioning unit people to see about implementing these MERV 13 or MERV 14 filters, which help with the air and the purifying of the air. We're just doing every possible sanitizing method that we can, and basically personal reassurance of the parents that we will take care of their child. Their health and wellness is the most important thing to us, and the importance of the vaccination schedule being followed, even more than the danger of the COVID, is the children getting off track and us losing the immunities that we have to all of these terrible diseases that we've made so much progress with. So that's what we're planning on, and that's what we're trying to do.
Thank you so much, Barbara. There's another question for you, Barbara, that came from Ken. How did your practice previously identify patients and conduct outreach? Were the GRITS reports easy to run, and what's the best way for a practice to learn and begin using the GRITS reports?
For us, we were not paying the attention we needed to GRITS reporting. We had our main contact there was Noreen DeHill and Shanrita McLean, and they provided us these reports on a monthly basis. We requested them. And I think from 0 to 36 months, you can request the report yourself from the interface, but the older reports, we were not able to request through our own means. So we engaged Noreen and Shan to continue giving us the reports, which is part of what's helping us. We also have reports that come out of our EMR system where we check to see patients who are greater than 1 year in the office since we've seen them. So we know that they're overdue for a checkup. So if we get them for the checkup, we grab them to come in and have their immunizations, of course, brought up to date. And then let's see, what was the rest of the question?
That was mostly it.
Mostly the reports we got. Shan and Noreen trained Vola on how to pull the reports for 0 to 36 months, and then they also provided them for the older ages. And that's really what helped us get our numbers in shape and eliminate the duplicates. It was shocking how many duplicates were in GRITS when we started seeing these reports. You could just knock off 100 or 150 every single time that you got a new report. And you would think, how did these people continue to show up in the system as not being, truly either not our patients or so many duplicates? But it's just the way that if they have gone to any other practice or received care at any other place, another record seems to be created again in GRITS. All it takes is a dash missing between a first and last name, or a slight misspelling, or maybe they went by a first name and then they went by middle name next time, but they're the same person and there's a new record. So getting those records tight and clean was a giant improvement for us. And now we're maintaining them. So that big effort is gone. So in working with them and working with our GRITS representative, to actually take the records out. I know that GRITS doesn't have quite as many employees as they need as a group to help keep those records clean. So they're doing the best they can with the systems that they've got. So sometimes it takes a little bit of time to get those patients actually back off of your list. You may not see them right away, but it really does. Working with the lists you can get and your contact with GRITS locally will make a giant improvement for your time, so that you don't waste time on patients that are either no longer in your group or they have actually received it but under a different name.
Gotcha.
So, okay.
Thank you, Barbara. And just a plug for our next webinar, it's actually focused on utilizing GRIT's reports. That webinar is going to be in October, and we'll discuss that towards the end as to how to register for the next session. And then a question was asked about the AC filter you mentioned, Barbara. Do you mind repeating the name of that filter or what it is that will help clean the air out better?
Yes, I'd be happy to. According to our, I double checked my notes. The filter is called MERV, MERV 13 is the one that actually fits our air conditioning unit. They're very pricey. They're, if say a standard filter that your system is using on a replacement AC unit filter, like the commercial units, is like $2. These are about $30. So you are looking at a major investment in cost. If you have, 20 or 30 filters throughout the entire system, depending upon how large your system is, it's a big financial investment. But in this time, it's something that you may want to consider as doing, because it, according to the CDC, this is stuff you have to research yourself and confirm. But they have led us to believe from the heating and air conditioning company that they may provide some additional protection and filtration. So it's a big investment. You have to change. If you normally change your filters twice a year, you have to change them 4 times a year. And so your contract with the AC people will be affected by that. But we are strongly considering doing that as we prepare for the next wave.
Thank you so much for providing that, Barbara. Are there any additional questions that our folks would like to ask before we move on? Hearing none, we will proceed. Thank you again for participating in today's webinar. We just have a few closing remarks. We would like to take a few minutes to thank all of those who helped make today's webinar possible. We want to thank the Georgia Cancer Control Consortium HPV Prevention and Education Work Group co-chairs who've been instrumental and supportive in us pulling this together, our members of the HPV work group, our subcommittee, Health Systems and Society Engagement Subcommittee members, the facilitator of today's webinar. Thank you so much, and Sasha, who've been instrumental in helping us get this done. Our partners at the Georgia chapter of American Academy of Pediatrics, who were instrumental in helping us ensure we got the CE credit paperwork submitted. Our National HPV Roundtable partners, we want to thank all of them and the efforts they've contributed in making today possible. A special thank you to the Georgia chapter of American Academy of Pediatrics, again, the National HPV Vaccination Roundtable. And just a reminder, for those who are seeking to obtain CE credits, we will be sending out a link to the recording for those who were unable to get in or were having issues logging into our session today. You will need to complete the evaluation, and at the end of today's webinar, you will be directed back to that evaluation page, and you will also receive the link in an email. Make sure you submit your evaluation by October 14th to receive CE credits for today, and you will receive a certificate of attendance via email by October 15th upon completion of your evaluation. If you are interested in joining our HPV work group, please contact Alma at the email that you see on your screen, and we've also put it in the chat box so that you can easily access it. If you also have any other suggestions on topics you would like us to cover in future sessions, please feel free to put it into the chat box at this time. And we also wanted to share a resource that was provided from the Georgia Primary Care Association. It's titled Catching Up to Get Ahead. It's a campaign to promote childhood immunizations, and it has a great toolkit as well. And we have put the link into the chat box as well for you. And again, thank you again for joining us today. We do want to make you aware of upcoming webinar sessions and the links for you to follow to register for those additional webinars. These are also going to have CE credits available for nurses. We have one on October 22nd. That's the one that will be covering grits and how to pull the reports out to get a list of patients who are due or overdue for immunizations. And we also have one on November 19th talking about, okay, so now we have the data, what do we do next? And again, those links are listed there, and the time will be the same from 11:30 to 12:30. Thank you again so very much for taking part in today's webinar, and we hope that you learned something new today.